Good afternoon, everyone. My name is Tiana Moore, and I'm the Policy Director at the UCSF Benioff Homelessness and Housing Initiative, BHHI. BHHI is a research and policy institute based at UCSF devoted to generating evidence-based solutions to prevent and end homelessness. We're incredibly excited to have you here with us for our webinar today on aging, health, and homelessness, an issue that has become increasingly important as the population of Californians experiencing homelessness ages. Today, we will start with opening remarks and framing, then present research findings, offer policy recommendations, and finally conclude with questions and answers at the end. Our panelists today include Dr. Margot Kushel, who is the director of BHHI, the principal investigator of the California Statewide Study of People Experiencing Homelessness, or CASPEH, and Health Outcomes for People Experiencing Homelessness in Older Middle Age, also known as Hope Home, and is the co-lead author of the CASPEH report. Her research focuses on reducing the burden of homelessness on health through examining efforts to prevent and end homelessness and mitigating its effects on health outcomes. Susan DeMorris is the director of the California Department of Aging, appointed by Governor Gavin Newsom to serve effective November 2021. As director, Ms. DeMorris is committed to stakeholder engagement, equity and inclusion, and system transformation to prepare our state for the year of 2030, when 1 in 4 Californians will be age 60 or older. Dee Dee Hancock is a lived expertise advisory board member. Following a job termination, Dee Dee lost the home she purchased as a single mom and became homeless. During her 7-year journey of homelessness, Dee Dee's purpose has been ignited to help end homelessness. Dee Dee is a member of the California Statewide Study Lived Expertise Advisory Board, Voices of Our City Choir, and the Homelessness Experience Advocacy Leadership, or HEAL, network in San Diego. During today's session, Dee Dee will be participating with her camera off. And finally, Marisa Espinoza is a policy analyst at BHHI. Her background is in direct service provision for people experiencing homelessness and legislative advocacy at the state and local levels. As a descendant of migrant farm workers and displaced people experiencing poverty, she is passionate about centering the voices of people with lived experience of homelessness, developing responsive and equitable public policy, and addressing racial disparities in health and housing. We'll now have Director DeMorris begin with some opening remarks.
Thank you so much, Tiana. It's an absolute honor to join you today for this webinar, and I extend my thanks on behalf of the Department of Aging and our Health and Human Services Agency for organizing this topic around older adults in housing. And I'm just honored to join this the esteemed panelists, and can't wait to hear from those who follow after me. A little bit about the Department of Aging. We are responsible in California for policies and programs that impact older adults, and we have the privilege of leading implementation on behalf of the governor of California's Master Plan for Aging, where housing for all ages and stages is goal number 1 of our 5-goal nation. As you heard Tiana say, by 2030, 1 in 4 Californians will be age 60 or older. We are projecting 10.8 million Californians will be in this cohort. And we know today that far too many will struggle to afford housing. We're seeing that play out daily throughout our state and nation. In California, 1 in 3 extremely low income renters are seniors. And a recent Harvard Joint Center for Housing studies report of older adults, and you know, this is new frontier that we have the UCSF study and Harvard focusing on older adult households. This is entirely new. Nationwide, older adult households represent over 1/3 of cost burden households, those spending more than 30% of their income on rent. And federal rental assistance programs support only 1/3 of older adults who qualify. In our network here in California, we have 33 area agencies on aging and a variety of contracted community-based organizations and services around the state. and they're all grappling with rising housing assistance needs for their constituents and their communities. Just one of our area agencies on aging reported to us that they receive 70 calls a day for housing help. The population experiencing homelessness is growing older. Our nation's population is growing older, so this is not a surprise. Over the past 30 years, the proportion of single homeless adults age 50 or older has increased significantly. There is a generational effect. People born in the second half of the baby boom, that would be the years between 1955 and 1965, have had an elevated risk of homelessness throughout their lives. The population of older adults experiencing homelessness is expected to triple between 2017 and 2030. And you'll hear from Dr. Kushel how those numbers are starting to play out today. The BHHI research has informed our understanding of this problem, what causes it, and the devastating consequences of homelessness in older adults. And I cannot thank Dr. Kushel and the team at UCSF for focusing on this population, because as I said, this is not an area of research that we can turn to. So their report is groundbreaking, not just for California, but for our nation. We know too that homelessness is a racial justice issue. Older Black Californians are disproportionately represented among older adults experiencing homelessness in our state. Persistent, systemic, historical drivers of homelessness disproportionately impact people of color, stemming from policies and practices that created unequal access to housing based on race, many that continue to this day. We see the effects of generational and ongoing racial inequality in housing today, where Black Americans are at 3 to 4 times increased risk of homelessness. So I want to commend the organizers of this webinar. This is a critically important topic, not just for today's discussion, but for the future of California and our nation. UCSF is a key partner to our state, and all of you who have joined, I'm looking at the numbers here, not seeing them on my screen, but to all of you who've joined today, you're absolutely essential to any progress we hope to make. Thank you for being part of this webinar, and please continue your advocacy on behalf of older adults. It's urgent. And it's now my pleasure to turn the next segment over to Dr. Margot Kushel, who will walk us through her slides.
Thank you so much, and thank you everyone for joining us. Today, I'm going to talk about 2 key studies that have helped us understand the crisis of homelessness among older adults. As Director DeMora said, the homeless population is aging. The proportion of single homeless adults who are at or older than 50 has increased dramatically. In 1990, we found that 11% were. In 2003, 37% were. And in the California statewide study on people experiencing homelessness, we found that 48% of adults experiencing single homelessness in California were 50 or older. Today, I'm going to talk about findings from 2 studies. Toward a New Understanding, the California statewide study of people experiencing homelessness came out in June 2023. In the coming months, we will produce a separate report focused on the urgent needs of older adults, and I encourage you to look for it. I will also be reporting on results of another BHHI study, the Hope Home study, or the health outcomes of people experiencing homelessness in older middle age. Hope Home includes only adults who are 50 and older and who are homeless at time of enrollment. The study started in 2013, and we have been following our participants every 6 months since, regardless of their housing. This study is funded by the National Institute on Aging. In the California statewide study, which was a representative study of all adults experiencing homelessness in the state, we found that the median age was 47. With a range of 18, which was the lower level in our study, and 89, The oldest participant we spoke to was 89. As I mentioned, 48% of the single adults were 50 and older. Among those adults who were 50 and older, 41% had never been homeless, not even for a night, before the age of 50. Amazingly, this confirmed and was nearly the exact number that we found in the Hope Home study, which takes place in Oakland. In Hope Home, we were very interested in how those older adults who first became homeless before 50 differed from those who were new to homelessness late in life. We found among older adults who first became homeless before 50 that compared to those who first became homeless after 50, they had more severe, adverse life experiences starting early in their lives. Because of these very difficult childhoods and early adolescence marked with trauma and difficulty, they tended to have low income attainment in early adulthood, no spouse or partner. They had mental health problems, which tended to start early, a higher prevalence of alcohol use problems and traumatic brain injury, and were much more likely to have experienced imprisonment. We will put the link in the chat, but this is a paper from Rebecca Brown et al. Amongst those older adults who first became homeless after 50, their stories were very different. These were adults who led quote unquote typical lives. However, they had worked low wage, often very physically demanding work throughout their lives, often holding down more than one job at a time to make ends meet. They did this until sometime after the age of 50, they had a discrete crisis that they could name, which was either a job loss, a breakdown of their marriage, their own illness or the illness of a spouse or partner, the death of their spouse or partner, or the death of their even older parent. When this happened and they were propelled into homelessness, we detected a tremendous lack of advocacy, meaning that they often did not take advantage of legal rights to which they ostensibly held, and a marked shortage of social support. And in this case, it wasn't so much that these adults didn't have family or friends, it was that they had such deep shame about their condition that they did not access it. Here is an older man who we met, who was living under an overpass with his wife, who was blind. This is what he told us. It was a lot of different things, but basically the new owners took over. We were being evicted. My wife, she had just got out of the hospital, had the stroke and was blind. So her daughter came up and said, "Don't fight it. Y'all can come stay with me for a couple of months and save your money." So we said, okay. They did not fight their eviction. After we moved out of the place, turned in the keys and everything, we went over to her house and she said, "Y'all can't stay here." Turns out her boyfriend did not want her very sick mom and her boyfriend to live with them. And I said, "I got $9 in my pocket." I said, "At least get your mother, spend the night because we don't have enough money to get a motel room." She said no. So that was the beginning. In the California statewide study, we investigated how people became homeless. Now I'm going to present some results on how the older adults came to homelessness. We found that among those adults 50 and older, almost 1 in 5 came directly from institutional settings. These were mostly prison or long-term jail stays. Almost half, or 46%, came from housing, but housing to which they held no legal rights. Housing in which they were doubled up, staying with family or friends without their name on a lease. Over a third, or 35%, came directly from housing to which they had legal rights. In most cases, participants were renters and had their name on a lease, although some were homeowners with a mortgage. Among participants 50 and older, we found that the main drivers of homelessness was their deep, deep poverty in a state with extremely high housing costs. Among all participants 50 and older, the median monthly household income in the 6 months prior to homelessness was a mere $920 a month. Amongst those non-leaseholders, the median monthly household income was $996 a month. 42% of them paid no rent at all, leaving them little agency when things got difficult. The median rent of those who did pay rent was almost half of their household income at $412 a month. Among the leaseholders, the median monthly household income was $1,100 a month, and their median monthly rent was $659. I have 2 points about that. The first is, if your household income is $1,100 a month, you can't possibly afford to pay $659 a month in monthly rent and sustain any crises. But also, there is no place in our state that you can re-enter the rental housing market for as little as $659 a month. As one of our participants said,
so I've given my whole check up many times just to pay my rent. Yeah, I would prefer to go broke, paying my rent, than to go broke and have nothing at all. Even if it costs me my whole SSI check, I don't care. As long as my rent gets paid, that's all I care. My bills, my lights, I don't care.
now we're going to look at experiences that people had during their time homeless. Among older adults in California, the vast majority were unsheltered. When we looked at all the places that people had spent time in the last 6 months, we asked them where they had spent the most time. 79% were primarily unsheltered, 21% staying in a vehicle, and 58% in a non-vehicle setting, which often looked a lot like this encampment that you see here. A mere 21% of the older adults in CASPEH spent the majority of their time sheltered. As one of our participants said about their lives,
I've tried many times on the streets to go to work, but it is almost impossible because you have to have the address, the mailing address, to get your documentation. I just got my birth certificate and my social security, my ID, all that stuff, you know, my income tax, all those records. I had just finally started getting back what I lost through my storage and being homeless, because those are important documentations that you need to get to work and get a loan and prove your history in that, the main thing. So homelessness, you just kind of lost, and you're just lost. That's what I say a lot, lost, right.
participants experienced incredibly challenging health. Among those 50 and older, over half, or 53%, reported that their health was fair or poor. This is an important indicator of people's risk for winding up in the hospital or dying in the coming year. Over 2/3, or 68%, reported that they had at least one major chronic health condition, like cancer, diabetes, or congestive heart failure. We suspect that these were underestimates because people had poor access to care. 43% of all of our participants 50 or older reported difficulty with one or more activities of daily living. And almost a quarter, or 23%, reported 3 or more limitations. A third, or 32%, of older adults reported having difficulty with mobility. When we looked at how people with activities of daily living limitations, where they were living, we found that 39% of those who were sheltered had one or more activity of daily living limitation, and 44 and 43% of those who were either outdoors or in a vehicle had one or more ADL limitation. In Hope Home, we were able to do cognitive testing on the participants. The median age of Hope Home participants was 57, but 26% had moderate to severe impairment on a screening test for global cognitive impairment. And 35% had moderate to severe impairment on a screening test for executive function. Executive function is the ability to follow sequence commands, such as if you want to get housing, you need to go to this office before noon on a Monday, pick up paperwork and bring it to that office. That is exactly the type of thing that someone with executive impairment cannot do. And yet that is what we ask people experiencing homelessness to do. We looked at a variety of measures of geriatric conditions or age-associated conditions. And again, this is from Hope Home, where the median age was 57. 27% had mobility impairment. 34% had had one or more falls in the prior 6 months. 45% had visual impairment that was significant wearing their glasses. So this was their best corrected vision. 36% had hearing impairment, and 48% had urinary incontinence. Imagine trying to find jobs or housing if you had no access to clean clothes and you were struggling with urinary incontinence. All of this leads us to say that when it comes to homelessness, 50 is the new 75. 38% of older adults experiencing homelessness in California's statewide study reported that at some point during this episode, they had wanted and sought shelter, but were unable to access it. Among those with 3 or more activity of daily living limitations, over half had told us, 53%, that they wanted shelter, but had been unable to access it. One of our participants described why. A lot of shelters they're not equipped for disabilities, for handicapped, disabled, They don't have handrails in the showers. They don't have a ramp, The disability can be a problem. They don't accept us in a lot of shelters. Our participants who were older experienced significant mental health symptomatology. 63% had some mental health symptoms, but these were really driven by anxiety and depression. 13% reported hallucinations. Among the adults 50 and older, we saw a significant amount of substance use. 30% reported using an illicit substance 3 times a week or more. This was primarily driven by amphetamine use, where 26% of the older adults, many of whom had significant functional limitations, reported using amphetamines 3 or more times a week. 3% reported cocaine, and 9% reported using non-prescribed opioids like heroin or fentanyl 3 or more times a week. Most of these participants co-used methamphetamines. 8% reported having a current heavy episodic alcohol use at least weekly. This is binge drinking. 42% of the older adults in CASPEH reported a complex behavioral need, either by saying that they currently regularly used illicit drugs, had heavy episodic alcohol use weekly or more, experienced current hallucinations, or had had a recent mental health hospitalization. 22% of all older adults in CASPEH reported a complex behavioral health need, as we described right before, and at least one activity of daily living limitation. This presents a real challenge for our current service system, because these are individuals who are both showing the signs of premature aging and have complicated behavioral health needs. our participants were extremely sick. Among the older adults, 37% reported a recent past 6 months emergency department visit. 25% reported a physical healthcare hospitalization and 5% a mental health hospitalization, all in the past 6 months. In Hope Home, we have followed participants for 10 years. In our initial 450 participants, we have 148 confirmed deaths. We found that the mortality rate in older adults was 3.1 times higher than the general population for men and 5.2% higher than the general population for women. These deaths were driven very much by the same things we see in the general population. 15% of those who died in Hope Home died from heart disease, 15% from cancer, and 12% from drug overdoses. In CASPEH, we looked at what kept people from resolving their homelessness. For older adults, far and away, the most common barrier that people faced was simply the extremely high cost of housing. 86% of participants told us that they simply could not afford their housing. When we looked at other barriers experienced by older adults, I want to point out several. 41% reported that they experienced discrimination when trying to rent a place. The dark line is that they said this was a little bit of a barrier, and the lighter blue is a lot. 44% told us that they lacked the necessary documents, by which I mean they didn't have a driver's license, ID, proof of income, or anything else. 33% noted that their record with the criminal justice system impaired their efforts to find housing. And 44% told us that their problems with their credit history or past eviction impaired it. Almost 1 in 3 participants, or 32%, told us that they couldn't find a place that met their needs due to a physical disability. As one of our participants said, most buildings that I have been in or been to have stairs, a lot of stairs. A lot of these apartment buildings don't have accessibility for a wheelchair or for a left leg amputee. So that's one of the major. And the money. I don't receive enough money each month to live on my own in an apartment. I don't have enough income. The population experiencing homelessness is aging. Many entering homelessness in late middle age for the first time. We see amongst older homeless adults the early onset of geriatric conditions, including cognitive, functional, and mobility impairment at ages much younger than we see in the general population. The experience of homelessness is harrowing and filled with despair. Homelessness systems need to be responsive to meet the needs of the aging population. And ending homelessness will require sustained efforts to address root causes, particularly the severe shortage of deeply affordable housing. It is now my pleasure to turn things over to my colleague, Marisa Espinosa, who is going to talk about some policy recommendations.
Thank you so much, Margot. So we've divided our policy recommendations into several areas, recognizing that policy improvements must address multiple domains where older adults are facing barriers to housing stability and moving through the system in an effort to regain housing. Responding to homelessness, housing connection, prevention, equity, and housing supports. Next slide, please. As we've seen today, the health needs of older adults experiencing homelessness, especially unsheltered homelessness, are not being met at the scale or pace that's required, and the policy response to homelessness must address systemic barriers that worsen conditions for unhoused older adults. We urgently need to reduce barriers to shelter access, and this means more training and staffing and more focus on accommodating functional, mobility, and cognitive needs among older adults, and exploring options to better support those with behavioral health disabilities. Another matter of urgency is creating rapid access to physical and behavioral health services. Too often, people aren't able to access these services when they want them, and expanding health-focused and evidence-based street outreach can play a role in bridging these gaps as well. And lastly, we want to emphasize the importance of shifting away from punitive or criminal justice system responses to homelessness, investing in things like non-police crisis response, and reducing things like forcible encampment removals and the many system penalties, like tickets and fees, that unhoused people face. These often compound barriers to housing and worsen conditions for people experiencing unsheltered homelessness, impacting health and overall safety. So based on all this, we're making the following recommendations in this area: reduce barriers to shelter access, create rapid access to physical and behavioral health services, expand and enhance street outreach, and shift away from criminal justice system responses to homelessness. In our next area, we need to provide older adults with high quality services and a direct path to permanent housing. Looking at how we improve this connection, strategies to expand the supply of deeply affordable housing must be deployed. This can include expanding federal programs like project-based rental assistance, while also prioritizing other programs that support creation of extremely low-income units and expanding subsidies, including tenant-based subsidies, to ensure more permanent supportive housing and deeply affordable ADA accessible housing can be built quickly. And to leverage the housing that is available and eliminate barriers, we need to not only increase services like case management, but also invest in programs and services that address housing discrimination and expand policies that reduce screening barriers for housing applicants. There's also a need for homeless service providers to be trained and equipped to provide services to older adults and create stronger partnerships between the homeless service system and aging services. And we know there's new funding opportunities and flexibilities that can allow health systems to provide more housing services through Medicaid or CalAIM, but these require better implementation and strategic improvement of partnerships and coordination to address gaps. So we make the following recommendations in this area: expand the supply of deeply affordable housing, eliminate barriers to access available housing, enhance homeless services capacity to meet the needs of older adults, and improve implementation of CalAIM. Now, moving along to prevention, we know that strong eviction and other tenant protections are key to keeping older adults housed, which can look like rent stabilization and just cause ordinances that we see at the local level. And most important is that our prevention strategies and resources target older adults who are more vulnerable based on health or disability and more at risk for homelessness. So we need to prioritize older adults that are living doubled up, who are at highest risk, as well as those with prior or recent experiences of homelessness, those with severe rent burdens, and those with ADL needs. When we look at the use of public benefits among homeless older adults, we need to work on solutions to address barriers to accessing these programs and really modernizing programs like SSI, which are still under the federal poverty level and impose unnecessary penalties to participants for things like saving money or getting help from family. Homelessness prevention services should be embedded into senior programs and services so that people are able to access help in places they already go or can connect easily. Adding to the pool of financial assistance is also needed, both one-time and long-term rental assistance, shallow subsidies, and other programs that older adults can access quickly to keep their housing. And lastly, older adults are exiting institutions like jails, prisons, and medical facilities without a plan and without a place to go, with, as we heard, 19% of older adults in CASPEH entering homelessness from these settings. So addressing this through targeted financial assistance, linkages to continuum of care services, and creating more low barrier reentry housing options is another key piece to ending older homelessness. So with this in mind, we're making the recommendations that you saw on the screen before. Now, for equity, we urgently need to center equity in housing and homelessness systems. Rooting out barriers that perpetuate racial disparities in homelessness will require expanding policies that reduce barriers for tenants in the private market. Another need is for more enforcement of existing laws that address discrimination, which is still happening on the basis of race, source of income, like having a voucher or rent assistance from an agency, as well as other protected classes. And we also need to strategize around how to address racially disparate outcomes in homeless service systems where people of color, especially Black households, placed in programs are not being supported to have the same success rate as other groups. And similar reforms are needed for coordinated entry, a system created to prioritize the most vulnerable for permanent supportive housing. So going forward, we're recommending, as you see here, remove systemic housing barriers that perpetuate racial disparities, combat ongoing discrimination in housing systems, address racial disparities in homeless service systems, and prioritize racial equity in coordinated entry systems. And so this is where we want to enrich supports for older adults to thrive in their housing and be successful long-term. High-quality support services will require long-term funding and increased capacity to provide robust staffing and programs on site for PSH residents. There also need to be coordinated service strategies that promote better health and stability for residents, including stronger relationships between service providers and landlords in the private market. And given the high level of functional mobility and cognitive needs for older adults exiting homelessness, we recommend developing targeted funding and replicating innovative models of contracting to provide HCBS and housing retention services, as these older adults often encounter barriers to receiving in-home support services, referred to as IHSS in California. For those with higher needs, we recommend exploring assisted living waivers and replicating programs that support those with high behavioral health needs and developing strategies to reduce those high costs. So with this in mind, we're recommending prioritizing high quality support services and permanent housing, implementing coordinated service strategies to promote health and stability in housing, and supporting ongoing functional mobility and cognitive needs of older adults. And now I'll turn it back over to Tiana. Thank you.
Thank you all for such an informative session. I'm going to ask our panelists to turn their cameras back on because we have a few questions from audience members that we'd love to get your thoughts and ideas about. I want to thank our participants for adding such really fantastic and rich questions to the chat, and we will try our best to get through as many as possible. The first question that we have is actually for Margot. What about homelessness do we think is the driving force to premature aging and behavioral health problems? Is it multifaceted, or are there kind of direct or singular causes that similar to substance use or others that you think are kind of driving these differences?
Yeah, thanks for that great question. I do think it's multifaceted. We know that living in poverty, we know living with lifelong exposure to racism ages people. This is often called the weathering effect. So part of it is we think that the people who bear risks for homelessness and are more likely to become homeless have experienced this weathering effect throughout their lives. But we also think that there are direct effects of homelessness on people's function and cognition. For instance, we think of function as an interaction between an individual's impairment and their environmental conditions. So someone, let's say, who experiences homelessness is likely to have had a much higher risk of impairments, such as more risk of acquiring injuries, work-related injuries, violence, wear and tear from difficult labor, and much less likely to have had good access to healthcare for things like knee or hip replacements. So they're much more likely, or to have had a stroke, let's say, from uncontrolled blood pressure. So they're much more likely to have an impairment. But then when you create that interaction with their environment, we can do a lot to equalize things and to make people's impairments have less of an effect on their function if we have control over their environments. I couldn't think of a worse possible environment than homelessness, whether you're sheltered or unsheltered. So then these things compound. We see a similar dynamic with substance use. Substance use can both precipitate homelessness because substance use disorders interfere with people's ability to function, interfere with social relationships, work relationships, etc. And thus it could, in someone who's already vulnerable, trigger the onset of homelessness. But once people are homeless, the incredible trauma that they experience while homeless, and the experiences that they have make it more difficult for them to reduce their use or seek treatment. We saw that again and again in the study of people, for instance, using methamphetamines, what we would call instrumentally, using them to help them stay awake and alert when they were being threatened, use it to have them, help them not be hungry. And also people had very poor access to treatment. And so we had a lot of people telling us that they were actively trying to get treatment and couldn't find any. So I think it is multifaceted. It's what we would call bidirectional. These impairments and limitations can increase someone's risk for homelessness, but once you're homeless, it worsens them.
Thank you so much for that, Margot. The next question we have is actually for Susan. Susan, would you mind discussing some of the implications or areas that we can potentially think about collaboration for California healthcare policy, such as Medicaid, Medicare, associated with this research? And specifically, the participant is interested in understanding how kind of the implementation of CalAIM and introduction of enhanced care management and community supports plays a role in this.
Great. I'm watching the chat, and this is a very well-informed group, and I'm so impressed. And let's see, I'm not able to take myself off of video, but I'm here for you. So, I want to point to a few things that are happening. Absolutely, our state Medicaid agency, the Department of Healthcare Services, is leading on all fronts with enhanced care management, community supports, of which the majority of interest relate to housing, and also really pushing the envelope in our federal partners, the Centers for Medicare and Medicaid Services, to expand temporary rental assistance through the Medicaid program. Other states are asking us, for the playbook on how to do that, because they're really taking a lesson from California and how we are integrating health and housing and the social determinants of health. So those are excellent examples of where that's happening today. In the case of CalAIM, enhanced care management and community supports, those are still relatively new. And the temporary rental assistance we're looking to extend is still waiting for federal approval. So the data is just coming in, and some of our foundation partners are reporting that out, as well as the Department of Healthcare Services through their dashboards. We're starting to see the numbers come in and the population that's being served. I want to point to some other efforts. In the chat, I saw Home Safe and some of the residential care opportunities that are happening through our State Department of Social Services in the Cal HHS agency, and the work that we're doing across agencies with the Business Consumer Services and Housing Agency and our new secretary there. So a lot of cross-agency and interdepartmental work happening. And of course, the partnerships between the state and our local agencies and our local counties, as well as the state's partnership with the federal government. And I'll point to All Inside, which is an effort that got underway earlier this year, where California was selected by the Biden administration to engage in a deeper partnership with our federal partners, such as HUD. And that's now underway. And much of this comes together at the Interagency Council on Homelessness, on which Dr. Kushel and I serve, along with other members. And it's just a wonderful cross-representation of various state and federal partners, as well as local experts and people with lived experience.
Thank you so much for that, Susan. The next question is from Marisa. As the population of people experiencing homelessness ages, what are some tangible steps that shelters and permanent housing providers can take to really ensure that they're sufficiently meeting the needs of older adults?
Yeah, thank you for that question. So I know we were talking earlier a bit about that training and capacity building that needs to happen in shelters. And obviously we know that can't happen overnight, although that really needs to be a high priority. So I would just want to point out that in the meantime, there does need to be that level of administrative advocacy, really looking at some of the different policies that happen at the ground level in shelters. For example, like length of stay policies. We know that a lot of unsheltered older adults are not trying to necessarily re-enter the workforce right away, but instead apply for income supports. And that doesn't happen in 3 months, which is often the length of time people get in a shelter. We also need to really think about physical accessibility, prioritizing older adults for the most accessible beds, especially non-congregate shelter settings. Those are really key to keep preserved and keep operating. We need to ensure that older adults are getting one-on-one assistance for housing navigation and case management, not just being left to navigate some lists and things like that. They're going to need that support. And of course, linking and building relationships with aging services and other organizations that are already providing that assistance to older adults and can help create those linkages to services and supports that are specific to older adults. And then I would say in the permanent housing setting, a lot of similar recommendations, but again, we did talk about operating subsidies, which are so key to keeping these projects in good working order and also provide robust supports. Like on-site services. But when it comes to that good working order, we're really thinking things like even having your elevators work is so key for older adults who are getting placed into permanent housing. So that's something that we really need to push for and advocate for and innovate as much as possible in that area. But again, in the absence of that happening overnight, we need to really strengthen and build those relationships with aging services. We need to really coordinate those services. And then, of course, we really need to prioritize older adults for the types of service-rich environments that they can thrive in when they have higher levels of needs. And, really thinking about those independent settings that we create for older adults, we know that many are not necessarily going to be appropriate for an SRO, just due to the fact that they wouldn't have their own facilities to bathe or use the toilet and things like that. So we really need to be thinking about prioritization, I think, when we look at the system and how we're placing folks in different settings. So that's what I would say to that question.
Thank you so much, Marisa. Margot, during your presentation, you discussed differences between older adults who first experienced homelessness prior to age 50 and those whose first experience was in older adulthood. Can you discuss how those differences might inform some solutions to ending homelessness for older adults?
Yeah, I think the fact that nearly half of older adults who first became homeless after 50, these folks tended to have much lower rates of behavioral health disabilities. These were folks who really had typical, often working class, lower working class, physically demanding jobs, wouldn't have come into contact with sort of behavioral health systems, of course, real systems, as much as just living on the economic edge, as far too many folks are. There really is no support network anymore. So many people have no pensions, are really living month to month their whole lives, and then something happens. To me, this is a really instrumental instruction to drill down on prevention. How do we locate these folks and keep them housed so that they don't enter homelessness? The thing that I didn't say in the presentation is I often hear policymakers maybe conflate this with non-chronic homelessness. The really horrifying thing is that these folks who enter in late life go on quickly to chronic homelessness. Many do have or gain sort of disabilities from strokes, heart attacks, other medical conditions. So they meet the disabling diagnosis thing, but they also meet the chronicity issue, meaning that once they become homeless in older life, they stay homeless a long time. And we found that amongst those first homeless after 50, the median length of time homeless was, up to or more than 2 years. Once they become homeless, they stay homeless. And we found in Hope Home that actually comparing those older adults who first became homeless after 50 to before 50, those who became homeless for the first time after 50 actually died, significantly more likely to die during the follow-up period. So to me, this says that we need to be doubling down on prevention. We need to be figuring out who's at risk. And because these are folks who become homeless after a sort of discrete event, we need to be on the lookout for those events, whether it's their own job loss, a job loss of someone in their family, an acute illness. Those are sort of sentinel events that could, in very vulnerable people, be an indicator to us. So someone applying for unemployment assistance, someone presenting to the hospital, someone where a family member dies, like these are ways that we could use to start looking at prevention things. Because these folks don't have behaviorally health disabling conditions, they often are not folks who need something like permanent supportive housing with really robust behavioral health supports to thrive. A lot of these folks are folks who need a voucher, hard as that is to find, housing navigation, and the ability to get back on their feet. We, in fact, have seen many of them re-enter the workforce, but they just are making too little every month. So I think we need to really bifurcate our efforts in a way and recognize that a fair number of folks who experience homelessness do have significant behavioral health needs, are gonna need the supports that we find in environments like permanent supportive housing with robust behavioral health supports. And many really need income support, some housing navigation, and then mainstream services for older adults, visiting nurses, other, in-home supportive services and other things that we just need to be sure to get to them.
Thank you for that. And Margot, stay unmuted because I have one follow-up question for you as well. So during the presentation, you discussed kind of a higher mortality rate for older women. What are some other gender differences, if any, that you've seen in the data for the older adults that are experiencing homelessness?
Yeah, so that's a really interesting finding. For those who missed it, because I went by quickly, compared to the general population, women who are older adults have about a 5-fold increased risk of mortality, and then men have about a 3-fold increased risk. So some of this is like a funky math thing that women live longer. So the baseline rate that we're comparing them to is the expectation that the women would live longer, and yet they don't. So in a way, you could think about it that homelessness removes many of the protections that you'd already have, or homelessness removes from women the protection that older women have in longevity compared to older men, if that makes sense. But what we have seen throughout CASPEH and Hope Home are some definite differences. And one that really comes to fore is the exposure to violence. In CASPEH, for instance, there was a tremendous amount of a risk of physical assault. And in Hope Home, we found the same thing, just tremendous amount of physical assault, where we said in CASPEH, in Hope Home, we talked about it as losing the protection that older adults usually have. Older adults actually usually have lower rates of assaults than younger adults, just because they're like less out in the world and there's less bi-directional sort of assault kind of things. But what we see in CASPEH and Hope Home is that women usually have less physical assault, they're equal. And then when you talk about sexual assault, it's really horrifying that young or old, there's an incredibly high rate of sexual assault, and that the women or trans non-binary folks have a much higher rate of experienced sexual assault than the men do. So physical assault is pretty equal between the genders. Sexual assault is very different, with women and non-binary trans folks having a significantly higher risk of sexual assault. The other thing I will say about violence, which is less of a gender thing and more of a homelessness thing, is that we see that when people are homeless, the assailant is at least half the time someone unknown to them, a stranger. And if you know anything about violence, you know that most violence is perpetuated against people within their own social networks. It turns out when you're homeless, you lose that protection. And that is true both for women and for men.
Thank you for that, Margot. In a previous response, Margot mentioned the need to double down on prevention. And Susan, I'm hoping that you can discuss a little bit about some of the key areas of the Master Plan for Aging that really address the housing challenges for older adults and center homelessness prevention for this population.
Absolutely. So just a couple months ago, we convened experts. Many of you I see are joining as participants in Los Angeles for a day-long session focused on preventing and ending older adult homelessness. This is a priority of the Master Plan for Aging. It is a high priority of our Impact Committee, which is our oversight committee that governs the Master Plan for Aging in our state. And it's also a priority for our Disability and Aging Community Living Advisory Committee, DACLAC. So we know that this is a priority. It's reflected in our current initiatives, and it's a two-pronged approach. So we're absolutely looking at preventive measures. Many of them are local, and I've heard all the words that we're using. We're going to be putting out a report soon after the first of the year to reflect back what we heard at this expert convening. The main topics are tenant protections. That's a big part of it, is trying to keep people who are housed, and to avoid displacement altogether. So that would be, legal protections, shallow rent subsidies, temporary rental assistance are some of the ideas that were explored. It's been discussed here, transitions. We know with this population, transitions from hospitals, emergency rooms, nursing homes, residential care facilities, that's a key juncture where we can capture people and prevent and avoid homelessness. I heard the word targeting. So targeting older adults, as you saw in Margot's slides, the prevalence of ADLs. So we need to do more targeting for this population and more tailored services. So people that need assistance with ADLs who may have durable medical equipment, we need to do more tailored services wherever they are. And then you've also hit on it, technical assistance and training. There's a lot of work that needs to be done to educate the housing sector about healthcare and the needs of older adults, whether it's gerontology, geriatrics, and likewise in the aging network, where housing has historically not been as significant of an issue as it is today. We need a lot of technical assistance and training around housing and how to navigate housing and what's available. So those are the strategies. They cut across prevention and ending. So, we tend to look at them more as tenant protections, transitions, targeting, tailoring, and TA and training, the 5 T's that were and much of it was reflected in your report.
Thank you, Susan. I think we have time for one final question. And Marisa, this one I think is great for you. So a participant had mentioned that the findings that we presented today indicate that a loss of income or under-enrollment in benefits programs are key drivers of homelessness for older adults. And also thinking about kind of the high rate of cognitive impairments that we also saw in this particular population. How does that inform some of the policy proposals that you discussed earlier today?
Yeah, thank you. That's such an interesting question. I think when it comes to that loss of income, again, I think we need to recognize that that safety net for older adults who are already on the edge of homelessness, it just typically isn't there. I think that we saw during the pandemic a huge rise in, communities being able to talk about and connect people to emergency rental assistance and make that much more available and get creative about ways to deploy that assistance and, even have organizations that weren't typically giving that assistance do that kind of work. And I think we need to see a whole lot more of that because unfortunately the status quo is that when you do have that senior living on the edge, they don't know where to go. And when they do go to that place, they're already out of assistance or they're on a wait list or they're told to call on the first Wednesday of the month or something like that. So having those prevention supports are really key. Again, we also know, though, that one-time help isn't always the most sustainable. There could be systemic issues going on, and that's where some of the more one-on-one assistance really needs to come in. You do need someone to come in and do more of a housing assessment, really kind of drill down into ways to get that person stable where they are or get them to somewhere that is going to be more stable. So maybe that's a shallow subsidy, maybe that's connecting them to that deeply affordable housing, et cetera. So it really feels like it needs to be a holistic strategy of strengthening that safety net and coming up with all the ways that the supports can be working together. I would say just to touch on that cognitive issue, that can look a lot of different ways, and I think a lot of us are seeing that, even in our housed communities, one of the things I would say is that for service providers and other providers that are out there working with older adults, the really key thing is always to promote independence. Like even if someone is maybe experiencing different types of cognitive issues, we know that stressful conditions are always going to worsen that. And it's always going to be really important to make sure that someone is connected to a provider, they're connected to the healthcare system, and they have the experts that actually know what they're doing, able to kind of work in line with housing providers. So again, that really does have to do with that cross-system collaboration and making sure that everyone is on the same page with where to go for the right information.
Thank you so much for that, Marisa. And with that, I'd like to thank all of our panelists who joined today for all of your wonderful contributions and a really rich discussion. Thank you all so much for joining us, and I hope everyone enjoys the rest of their day.